Understanding and managing cardiac medications is an essential part of nursing and healthcare practice. These medications play a critical role in the prevention, treatment, and long-term management of cardiovascular conditions such as hypertension, heart failure, atrial fibrillation, coronary artery disease, and myocardial infarction. Nurses are often at the forefront of administering these medications, monitoring their effects, educating patients, and identifying side effects or complications early. This video will cover 4 major classes of cardiac medications: beta blockers, ACE inhibitors, diuretics, and anticoagulants. Let us begin with beta blockers, also known as beta adrenergic blockers. These medications block the effects of adrenaline and noradrenaline on beta receptors in the heart and blood vessels. They primarily work on beta 1 receptors in the heart, which leads to a reduction in heart rate, blood pressure, and myocardial oxygen demand. Commonly used beta blockers include metoprolol, atenolol, bisoprolol, propranolol, and carvedilol. The clinical uses of beta blockers include management of hypertension, angina, post-myocardial infarction, heart failure, and arrhythmias, such as atrial fibrillation. In hypertension, beta blockers reduce cardiac output and inhibit renin release from the kidneys. In angina, they decrease the heart's workload and oxygen demand, thus reducing chest pain. In heart failure, especially chronic systolic heart failure, carvedilol, bisoprolol, and metoprolol succinate have been shown to improve survival and reduce hospitalization. In atrial fibrillation, beta blockers help control ventricular rate and reduce the risk of tachycardia-induced cardiomyopathy. When administering beta blockers, nurses should monitor heart rate, blood pressure, and signs of worsening heart failure such as shortness of breath, fatigue, or peripheral edema. Beta blockers are contraindicated in patients with severe bradycardia, second or third degree heart block, and decompensated heart failure. Side effects may include bradycardia, hypertension, dizziness, fatigue, cold extremities, depression, and sexual dysfunction. In patients with asthma or chronic obstructive pulmonary disease, non-selective beta blockers like propranolol may cause bronchospasm and should be used cautiously. Next we move to ACE inhibitors, or angiotensin-converting enzyme inhibitors. These medications inhibit the enzyme responsible for converting angiotensin 1 to angiotensin 2, a potent vasoconstrictor. By blocking this conversion, ACE inhibitors reduce vasoconstriction, lower blood pressure, and decrease aldosterone secretion, which leads to reduced sodium and water retention. Common examples of ACE inhibitors include enalapril, ramipril, perindopril, lisinopril, and captopril. ACE inhibitors are primarily used in the management of hypertension, heart failure, and post-myocardial infarction. They are also recommended for patients with diabetes or chronic kidney disease, as they offer renal protection by reducing proteinuria and slowing the progression of nephropathy. In heart failure, ACE inhibitors reduce afterload and preload, thereby improving cardiac output and symptoms. They also reduce hospitalizations and improve survival. Nurses should monitor blood pressure, renal function, and serum potassium levels when patients are on ACE inhibitors. The most common side effect is a dry persistent cough, which occurs in up to 20% of patients. Other adverse effects include hyperkalemia, hypotension, dizziness, fatigue, and renal impairment. A serious but rare side effect is angioedema, which presents as swelling of the face, lips, tongue, or throat and requires immediate medical attention if a patient develops intolerable cough or angioedema. An angiotensin receptor blocker, or ARB, such as losartan or candesartan, may be considered as an alternative. Now we turn our attention to diuretics, which are medications that promote the excretion of sodium and water through the kidneys. They are commonly used to manage hypertension, heart failure, edema, and fluid overload. There are several classes of diuretics, including loop diuretics, thiazide diuretics, and potassium-sparing diuretics. Loop diuretics such as furosemide and bumetanide act on the ascending loop of Henle and are potent diuretics used in cases of acute pulmonary edema, chronic heart failure, and fluid overload. They work quickly and effectively but can cause significant electrolyte disturbances. Thiazide diuretics such as hydrochlorothiazide and indapamide are used for long-term management of hypertension and mild fluid retention. They act on the distal convoluted tubule and are less potent than loop diuretics, but better for outpatient use. Potassium-sparing diuretics such as spironolactone and eplerenone act on the collecting ducts and help conserve potassium. They are often used in heart failure and in patients at risk of hypokalemia. When managing patients on diuretics, nurses must monitor fluid status, daily weights, electrolyte levels, renal function, and signs of dehydration or volume depletion. Loop and thiazide diuretics can cause hypokalemia, hyponatremia, dehydration, dizziness, and hypotension. Nurses should encourage patients to consume potassium-rich foods unless they are on potassium-sparing diuretics with spironolactone. Nurses must watch for hypokalemia and gynecomastia in male patients, which is a known side effect. Regular blood tests are essential to adjust doses and prevent complications. Finally, we examine anticoagulants, which are medications that prevent blood clot formation. They are used in the prevention and treatment of venous thromboembolism, including deep vein thrombosis and pulmonary embolism, in atrial fibrillation to prevent stroke, and in patients with mechanical heart valves or those at high risk of clot formation. Anticoagulants include heparin, low molecular weight heparins, warfarin, and the newer direct oral anticoagulants, or DOACs. Heparin is given intravenously or subcutaneously and works by activating antithrombin, which inhibits clotting factors. It is used in hospital settings for acute treatment and requires close monitoring of activated partial thromboplastin time or up to ensure therapeutic levels. Low molecular weight heparins such as enoxaparin are more predictable in their action, have longer half-lives, and do not usually require routine monitoring. They are commonly used in postoperative settings and for bridging therapy. Warfarin is an oral anticoagulant that works by inhibiting vitamin K-dependent clotting factors. It requires regular monitoring of the international normalized ratio, or INR, to keep levels within the target range, usually between 2 and 3. Warfarin is affected by diet, medications, and illness, making it more complex to manage, but it remains important for patients with mechanical valves or high-risk conditions. DOACs such as apixaban, rivaroxaban, and dabigatran offer a fixed-dose alternative to warfarin with fewer dietary restrictions and no routine monitoring needed. They are increasingly used for non-valvular atrial fibrillation and for treatment and prevention of venous thromboembolism. Nurses managing anticoagulants must be vigilant for signs of bleeding such as bruising, hematuria, melena, nosebleeds, or prolonged bleeding from cuts. They should educate patients to avoid activities that increase bleeding risk. Use soft toothbrushes and electric razors and report any unusual symptoms immediately. For patients on warfarin, it is essential to maintain a consistent intake of vitamin K-rich foods and attend regular INR testing. For those on DOACs, adherence is critical since missing doses can quickly reduce anticoagulant effect. Drug interactions are a major concern with all anticoagulants, especially warfarin. Nurses should check for interactions with other prescribed medications, over-the-counter products, and herbal supplements, which can affect clotting status or increase bleeding risk. Patients undergoing surgery or invasive procedures may need to pause anticoagulants, and this should be carefully coordinated with medical teams. Patient education is vital across all these medication groups. Nurses must ensure patients understand their purpose, dosage, timing, side effects, and when to seek medical help. Encouraging patients to carry medication alert cards or wear medical ID bracelets can be helpful, especially for those on anticoagulants or multiple cardiac drugs. Monitoring vital signs, blood tests, and symptoms regularly helps detect complications early and ensures medications are achieving their desired effect. Nurses should collaborate closely with pharmacists and doctors to review medications regularly, especially in older adults who are more susceptible to side effects and drug interactions. In conclusion, beta blockers, ACE inhibitors, diuretics, and anticoagulants are essential tools in managing cardiovascular disease. Nurses must be confident in administering these drugs, recognizing their mechanisms of action, monitoring for side effects, educating patients, and escalating care when needed. By understanding these medication classes in depth, nurses play a vital role in improving patient outcomes and ensuring the safe and effective use of cardiac therapies.